this weaning failure, where there are a few things that are very classical that you can explain, you can understand by looking at lung ultrasounds and diaphragmatic ultrasounds. Like for example, the patient that is there now at the moment, he can be actually evaluated very well with the lung ultrasound, and a diaphragmatic ultrasound, to understand whether the patient on the ventilator, critical illness, neuropathy. See that patient, we just did 3 days. Yeah, some days ago we did critical illness, neuropathy, myopathy. That patient fits classically into critical illness, neuropathy, myopathy because of the fact that he's got proximal muscle weakness. He's got distal muscle weakness. Proximal muscles are not that bad, so it is not critical illness myopathy. It is critical illness neuropathy. You understand? CIN this is. Because his proximal muscles are okay, he's able to lift his hand up. But his distal muscles are very weak. Tell him to hold it is not very tight. It is not very tight. Okay, so he's classical in that case, which probably may have also diaphragmatic dysfunction. No, so we normally, what does anesthetists make the patients to do after the anesthesia to know whether they'll come out of the neuromuscular blockade? They tell you to lift the neck, isn't it? You don't lift the neck. So this activity is kind of a good activity to be done in patients who are just about to be extubated. Because what happens with the neck lift is we say that the nerves that are responsible for getting the neck to be lifted is the same nerves that are required for a diaphragm to move. You understand? So the neck lift can be kind of a reasonable surrogate for diaphragmatic weakness. So if the patient is able to lift the neck away, then the diaphragmatic weakness is done. But that is just a part of the entire examination. But you need to do all these things to understand further. You can't just take one particular exam. You can't do just a forced vital capacity or 4 NIF and tell you this patient is. Okay, so let's go to lung ultrasonography. You have diaphragm after this or now?
So in the end, I have diaphragmatic exertion.
Chicken, let's do it.
Good morning everyone. So today's topic is lung ultrasonography. So there are in USG when we do of the lungs, so there are 3 probes which are present that we use. One is the phased array probe, one is the linear array, and the curvilinear probe. So the phased array is low frequency, it's used for chest, abdominal and transthoracic echocardiography, usually between 3 to 5 megahertz. Linear array is the high frequency vascular probe, and curvilinear is the mid frequency for chest, abdominal, USG. So now what are the prerequisites for scanning? Comfortable position for the patient as well as for ourselves, probe placement, and areas to be scanned of the lung, that is all the 4 quadrants of the lung bilaterally, and the posterior part by placing the probe along the posterior axillary line, scanning to a depth of 15 to 20 centimeters to evaluate basic lung pathology, and 8 to 10 centimeters to facilitate the artifact analysis. Diaphragm and probe should be kept in between ribs along longitudinal axis of the patient with marker towards the head end. Now image interpretation. So we usually see for we have to interpret what we see under these 4 pointers. That is identification of the pleural line, artifact analysis, lung sliding analysis, and evaluation for pathology. So now pleural line. So pleural line basically, how do we see? So in a normal lung, the lung pleura normally we see A lines. So what are these A lines? So these are basically the horizontal lines that we see. So there are 2 dark shadows that we see here. This is the 2 dark shadows which moves usually when in a normal lung. So there is this hyperechoic P line, this one. This is the normal pleural line and the A line by side of the. So basically, it's like when we put a probe, we see 2 shadows of the ribs, and in between that we see the lung pleura with slides.
So when you do an echo for the pleura, you need to have this particular view. You need to have this view. You will have ultrasound. When you put the probe vertical with the pointer facing outwards. You should have this view where you have rib, and this in the middle. Okay, it's like a bat swing. So this has to be this way itself. Okay, it has to be this way. It has to be seen like this. Otherwise, you're not doing a proper lung ultrasound. So in your image, you should have rib and pleural. Clear on this? That is clear. It has to be. What you're seeing over here, these are A lines. And this will keep coming again and again and again. This is basically a reverberation artifact. It is basically saying that the lung is so clear that the light from the top is reverberating again and again, again and again. So if you see an A line, you can reasonably assume that this lung is normal. This lung is completely normal. You can reasonably assume this. Clear on this? When you have A lines, it's coming like this, so it's going ahead, going ahead, going ahead. You can reasonably assume that the lung is normal. Clear on this? Is it clear? I don't want to hear the patient is very bad and I can see A lines and B lines. It's all. I don't want to hear that because it's A lines are normal. Okay, don't worry. It's a reverberation artifact. Okay, we can. Alright.
Then B lines. If one or two of these are present, then these are basically the Z lines. And if it's present all over, then it is pathological. So, for example, in a lung which we screen, supposing we get A lines and there are like one or two B lines which we screen. So, these are basically the Z lines. It doesn't indicate towards any pathology. So, if there are a lot of B lines, so that means we are dealing with some of the other underlying pathology. So, this basically, see, these few that we see, this is not pulmonary edema or is not suggestive of pneumonia or anything of that sort because we have A lines as well. In case if you are dealing with any pathologies, then we won't be able to see the A lines at all. It will only be B lines all over. Can you all appreciate this movement?
So those are B lines. The ones that are moving.
So now what are E lines? These arise superficial to pleural line and is seen in emphysema where pockets of air creates air tissue interface. So basically we can demonstrate this with a phase direct transducer and the vertical bright like these ones. So this is our pleural line. So these ones that are originating, these are the E lines. Then lung sliding. So lung sliding is seen in a normal lung, okay, where we saw the pleural line on the first picture that we saw. This, the movement of the mucus. This is a normal lung which is sliding. So there are two things, sliding as well as shredding. So sliding is a normal lung parenchyma which moves along the inspiration and expiration. Then pleural effusion. So USG can detect even small pleural effusion which is less than 50 ml, and there are two signs that we see in pleural effusion, quad sign and sinusoidal sign. So now what are these? So quad sign, basically it is a quadrilateral which is formed by the chest wall above, pleural line below with the shadow of two adjacent ribs. This one, this is a quad sign. So it is formed by chest wall, pleural line and with shadow of two adjacent ribs. And a sinusoid sign. Sinusoid is basically seen in the M mode where the sinusoidal movement of freely floating lung which each inspiration denotes presence of effusion. This basically is wavy which we see in the M mode, and we see that the lung flow actually, I will show you video right now. But then this is seen in the M mode. Okay, the lung floating is seen. So basically quad sign and sinusoidal sign in the pleural effusion is what we see. Then when there is an alveolar consolidation, so in consolidation what do we see? We see that there is hepatization of the lung parenchyma and the dynamic air bronchogram movement, that is outwards towards the transducer with inspiration and inwards away from the transducer with expiration, the dynamic air bronchogram. So this is basically hepatization of lung parenchyma. And we see a shed sign as well, like the sliding that we saw in a normal lung parenchyma. So that appears like a
Okay, go ahead.
Like that. Then atelectasis. So in atelectasis what happens? There is absence of sliding and pulsing. So vertical lines below the pleura due to cardiac pulsation and static air bronchogram with respiration. So in consolidation, the air bronchogram moves along with respiration. But in atelectasis, it is static. With respiration, it doesn't move. Then alveolar interstitial syndrome. So it is basically multiple B lines are seen with at least minimum of 3. So now how on basis of the B lines also we can somehow categorize into mild disease and severe disease. So in mild disease the B lines are 7 millimeters apart from each other, whereas in pulmonary edema they are very closely spaced, like less than 3. That means we see a lot of B lines in a particular segment that we are seeing. And in severe disease, B lines become confluent, creating a whiteout pattern that is equivalent to GGOs on CT. So now pneumothorax. So pneumothorax means there is absence of V lines, there is no sliding, there is no pulse sign. So we see nothing pneumothorax. This basically we can demonstrate in M mode properly. So in which we don't see any lung sliding, we don't see any pulse sign, or there are no P lines. So stratosphere sign, basically pneumothorax we see the stratosphere sign. So what is stratosphere sign? So lung point, it is the junction between sliding and non-sliding lung. And stratosphere sign is seen in M mode, which are laminar and horizontal artifacts seen below and above the pleural. This is the stratosphere sign that we see. So now, so this is a short. This of the signs that we see. So seashore appearance. So seashore appearance basically is in M mode that we see of a normal lung. So it is basically like when we place the transducer and we put the M mode. So in that we see a sandy beach appearance, that is of a normal lung that we see. If there is a quad sign or sinusoidal sign, that means we are dealing with pleural effusion. In shred sign or tissue-like sign, that is consolidation. Lung rockets, like we see lot of D lines, so that is interstitial syndrome. Stratosphere sign in pneumothorax, lung point in pneumothorax. So now there is something which is known as blue protocol. So blue protocol is basically bedside lung ultrasonography in emergency. Okay, so in that, so there are various profiles which are there. A profile, B profile, B dash profile, C, AB profile and flaps profile. So in that, what do we see? In A profile, that is lung sliding is present along with A lines. So that is like it is normal, or if lung size. So if you see A lines along with sliding, that means it either could be a normal lung or normal, or if lung, and if A lines are present but then lung sliding is not present, so that could be pneumothorax. Then if DVT is positive, we are dealing with pulmonary embolism. If DVT is negative with flaps, I will tell what flaps is. Then we are dealing with pneumonia. If DVT and flaps are negative, then it is suggestive of severe asthma or COPD. Now B profile is what? So B profile we deal with lung sliding along with lung rockets. So that means we are dealing with pulmonary edema. And B dash profile, B profile with abolished lung sliding, that means we are dealing with pneumonia. So B profile में lung sliding with lung rockets means there are B lines also, sliding is also present, so that means there is no underlying pathology, it's just edema, there is no pneumonia or consolidation of anything of that sort. In B dash profile, when we have B lines but lung sliding is absent, so that means we could have a shredding or something of that sort, that means we are dealing with probably with pneumonia. In C profile, the A lines are thickened and there is irregular pleural line, then also we could be dealing with pneumonia. Then AB profile, when half A profile at one lung and a half B profile at another, we could be dealing with pneumonia. And that means we have few A lines and very few B lines. Like there is consolidation supposing in the lower zone or mid zone somewhere, but the rest of the lung parenchyma appears normal, like we have A lines. So that means it's localized, so that could be pneumonia. Then flaps profile, that is posterolateral alveolar and or pleural syndrome, we could be dealing with pleural effusion, consolidation, pneumonia. There is a tabular form of this. So basically it's, we are seeing, what do we first see? We see first if there is lung sliding is present or not. Supposing it's present, then we have A profile, we divide it into A profile, B profile, AB profile or C profile. If it's absent, we see B profile as well as A profile. So in A profile, so what was in A profile? What we are seeing that we have got lung sliding along with A lines. So if we have A lines, so supposing if there is if venous system thrombosis, if there is no thrombosis or if it's present. If thrombosis is present, that means we could be dealing with P. That is what we had seen if DVT is positive. Okay, so this is basically a tabular form of the previous what I had shown.
So go back. So the A profile. So you've understood this word. So important this is. See, when you have the A profile, there is anterior lung sliding with A lines. Okay, what does this mean? That the lungs are normal. Are you understanding? It's such an important protocol. Say A profile means the anterior lung is sliding with A lines. So if that means the lung is normal. So if the lung is normal, you have to rule out pulmonary embolism. Okay, that's something that can be seen. And sometimes you may have pneumonia there. Sometimes, very very rarely, everybody is negative with flaps that is. Okay, so go to A profile now. So once you get an anterior lung sliding with A lines, as I told you, more likelihood that the lung is normal. So if the lung is normal, you have to look at venous system thrombosis. That's why if it's present, that means if DVT is present, then that is pulmonary embolism. That's why the patient is breathless. This is a protocol done for breathlessness. You are understanding the protocol for breathlessness. When the patient comes with breathlessness, it's A profile. There is no thrombosis. Then you look for flaps. What is flaps? You understood this much? अभी तक इतना समझ में आ गया? So when a patient comes with breathlessness, how to go ahead? So flaps. So before they go to the rest. Okay. Yeah.
So basically, what is flap? So there is something which is known as a blue point. So we put our both the hands on both sides of the chest. So the midpoint of the
No. So it's not like that. Such again. So perhaps you should do all these things. I have taken this lecture in the past. So you'll never remember it. I don't need to do it. I can remember. I know it. But you all need to do it, right? So when a person is semi-recumbent or sleeping, so you keep your so blue, it's called as a last point is one of the blue hands. Blue hands be doctor's hands. That's what we say. Okay. So the little finger has to be joining the clavicle, like this, and it should be just touching the sternum. The thumbs are not counted on this. So then you put the thumbs right here on this. So average hands जो हमको मिलते हैं इसमें 2 points आते हैं. The upper blue point that is in the center, that is somewhere between the middle finger and ring finger. Between the middle finger and ring finger, the point that reaches, that is the upper blue point. Alright, and the lower blue point is in the center of my palm. So when I keep this like this, when I keep my fingers like this, my little finger is flush with the clavicle. My little finger is flush with the clavicle. My other fingers are kept right below this, and my thumbs are on top of this. Thumbs are not included in this particular image. Only on my fingers. I keep this like this, touching very flush, very close to the sternum margin. What I see between the middle finger and middle finger and the ring finger, this is my upper flap point. Point number 1, upper blue point. It's called upper blue point. And the one that is below this in the center of my palm is the lower blue point. If I extend this backwards towards the anterior axillary line, the point that I get from there and I focus inside, if I get a consolidation, then that is pneumonia. That is flap point. Okay? Clear? Understood, no? So I need to do that and then focus from there. I get the consolidation. That is the segment in which the lung is not, you cannot see the lung otherwise. So to see the posterior segment. So that's why if the patient is breathless, patient does not have pulmonary embolism, patient is not having A lines at least in the anterior zone, you need to see that particular part. And that particular part you can see by doing the black point. So, and it is it is classical and 100% pneumonia. I have done this many times in the ICU. Many times I have shown you, I'll see the black point क्या लिखा है.
So this algorithm doesn't aim at providing the diagnosis, but it indicates a
so important to see if you get this all negative and flaps are also negative, you are dealing with COPD and asthma. You can actually diagnose it, okay, because it's nothing else. Yeah.
So if lung sliding is absent, so then we go for the B profile. So in B profile, what we had seen was if lung sliding with lung rockets are present, then it could be acute pulmonary edema. Supposing if B profile is if B lines are present, but with abolished lung sliding, then we are dealing with pneumonia. So then in A profile, what we saw was with lung point, that was pneumothorax, and without lung point, then we need to diagnose.
What is lung point?
So lung point is basically junction between sliding.
How do you find this?
Non-sliding lung on the M mode.
What do you see on M mode?
Loss of
So-
stratosphere.
What is your name? No.
Seashore और वो
नहीं. What is your name? So I have taken so many videos and shown. कितने videos हैं हमारे और हमारे ICU से.
in the mode, sir, when we place, so the point at like when we see there is sliding, but there's a particular segment where the sliding disappears and we just see the vertical, I mean, sir, horizontal lines.
No. So see, you must understand what is the M mode. What happens to a lung point is you have normal lung and no lung. Normal lung and no lung. That is the point you're looking at, where there is normal lung and there is air. Are you understanding? Pneumothorax. Okay, you're looking at a pneumothorax maybe. Okay, or a hydrothorax. That means there is normal lung because it is a lung that is collapsed. It's a lung that is collapsed. Otherwise, the pattern of the lung is okay. It is just collapsed because of air. Right. So it's a lung and no lung. This is the point. That is the point you're looking at. So when you look at that particular point, you have to search for that point. It's not that you get it. You have to keep searching. I have the video. I don't know who has the video of that. Gauri had it given to two, three people. Who has it? I don't know. रश्मि से पूछना पड़ेगा वो वीडियो उसके पास रहेगा. So you have that area. So you will have A lines sliding and no sliding, no lung only.
So that means it is vertical lines.
Nothing is there only. There is no sliding only. So it's a point. It's a point that you have a sliding coming here and then nothing ahead here. Are you understanding? Here you have A lines. Here you have A lines because of the fact that there is lung under that. Whereas this point is that point. You know, if you have a lung that's collapsed, it is this point where there is lung and there is no lung. So you are placing a probe right here. Are you understanding? If you are placing a probe right here, you are getting lung and no lung. So you will get sliding, and this side there is no sliding. For example, if this side sliding, and here there is no sliding, there is nothing at all there. Black color. You are understanding? Huh? That's how you can say, okay, but because M mode will cut it right here. So you may not see this and this. You understand? Unless you are cutting the M mode in such a way that you're cutting it right over here. Sometimes that the lung comes inside and goes, you can see that. Okay? You can do it like that. You cut it here and you find the lung starting entering and going out, you can see stratosphere versus the scientific appearance, something like that. You understand? That is called as lung point or hydro point. Okay?
Then diaphragm. So diaphragmatic movements we can see it by eyeballing, that is like the normal diaphragm what we see, or there is something which is known as diaphragmatic excursion. So diaphragmatic excursion usually we do it in there are 3 readings that we take. So we take it in a patient who is there's normal respiration. Then we have the patient to deeply inspire air, and then we take an average of this, and then in males usually it is 1.8 plus minus 3, and in females it's 1.6 plus minus 3. So
You didn't understand what it is. I don't think you understood.
I am
Come sit. So diaphragm, let's be there. Okay, you have any more slides?
No, sir.
No, sit. So there is a lot more you need to do this. So take for example the patient that is lying down there. The patient that is lying down. So you have a present patient. Go, please have a look. It's important that you register it in your mind. Your eyes, brain will understand what your eyes see.
Sir, then uska M mode, I have the video on my phone of that patient.
Of that patient. It's on your phone. You put it on this one. So what have you done? Show me what you have done. So
I saw the diaphragm. When I got the diaphragm, I froze it.
This patient is on the ventilator, no?
Yes.
So you never do it with the patient on the ventilator. Okay. So you never do it when the patient is on the ventilator because the ventilator push no air. The ventilator is pushing air. So what are you going to get with that? A diaphragmatic ultrasound is done when the patient is off the ventilator or on a T-piece. Are you understanding? So if you want to do diaphragmatic ultrasound, what do I require to do? I need to take the patient off the ventilator. Understanding? If I want to do diaphragmatic ultrasound for venous failure, okay, that means I need to take the patient off the ventilator, put him on a T-piece, do the diaphragmatic ultrasound. What you can do on a regular basis on patients with mechanical ventilation is look at thickness of diaphragm. Look at the thickness of the diaphragm at the end of expiration. Are you understanding? Clear on this? we can look at the thickness of the diaphragm on a regular basis, like how we do diaphragmatic ultrasound for rectus femoris or vastus intermedius. So similarly, you can do thickness of the diaphragm for understanding whether the thickness is coming down. When the thickness is coming down means there's atrophy of the diaphragm. Ventilator induced diaphragmatic atrophy is happening. You understand? So that you can do. But if you want to do it for weaning failure, you need to actually take the patient off the ventilator, put them on the TPs, and how do you have this patient? The patient should be calm, quiet. You can either do it in the supine position, you can do it in the semi-recumbent position. It's always comfortable to do the semi-recumbent position. Which probe do you use? So which probe do you use?
Curvilinear.
So usually you want to use a cardiac probe. Okay, you can use a curvilinear probe also, but the footprint is very large. Okay, so you use a curvilinear probe. What you will see, you will keep the probe marker facing upwards. But the easier option is to use the cardiac probe. Okay, use the cardiac probe, keep it in the mid-clavicular line. Use the cardiac probe, keep it in the mid-clavicular line. This is taken from the mid-clavicular line. This is not taken from the axillary line. What you are seeing over here is actually either over the anterior axillary line or it is a mid-clavicular line. Are you understanding? So I am not putting it here. You normally do for ultrasound. I am doing it here. So I can use a small phase cardiac probe. Okay. And when I put that, I will see the liver on one side and I will see nothing on the other side. Okay. I will see liver on one side and actually lung on the other side. You are actually looking through the liver. You are looking through the liver. You see, you are looking through the liver. Okay. So you are seeing the liver and this is normal lung. That's why you are not seeing anything here. You understand? What you are seeing hyperechoic over here is the diaphragm. Clear? So the first thing that you can see whether the diaphragm is working or not is by just keeping it over here. And if the entire thing, the lung comes home like this and goes back, entire thing comes inside and goes out. Or if you put it on, when you're doing your diaphragmatic ultrasound from the pleura and you see the entire lung coming in and going out, this is called as curtain sign. Okay, it's called as curtain sign. What happens is that the entire diaphragm is moving in such a way that its lung is coming in and going out, means there is no point, the diaphragm is good. There is no issues in the diaphragm. Are you understanding? If the entire diaphragm is moving and the entire field is going out and coming back, okay, this means the diaphragm is working well. There is nothing to be worried. Are you getting the point I'm telling you? That's called curtain sign. That thing entire moving. That's called curtain sign. Okay, that means you put the probe here, you find the entire diaphragm going up. That means the lung is coming, obliterating and going back. Means things are okay. There's nothing to be worried. Okay, when that doesn't occur, that is when you do the other kind of testing, where you put the probe in the mid-clavicular line, go upwards, and what you see over there is you find this kind of a shadow, and this is not moving, this remains here. Then at the most deepest part of that shadow, this is usually done at a distance of around 10 centimeters. So you have to lower it to 10 centimeters. You should be able to see the whole convexity. If you are not able to see it, try moving it anti-clockwise. Okay, try moving it anti-clockwise. On this side it is anti-clockwise and this side it is clockwise. So move the probe anti-clockwise. Okay, and you may probably see the top of the diaphragm better. You are trying to see the top of the diaphragm here. Are you understanding? So if you don't get the image properly, you start moving it. See, you can do this. You understand the way to do it. Okay, others it's very difficult to tell you how to do it. Okay, so mid-clavicular anti-axillary के बीच में I'm going to put it. I'm going to keep turning it anti-clockwise, and I will probably get this particular image. Once I get this particular image, then I put the M mode right in the center of that image. I just put the M mode there. I press M mode, the line will come there, and I press M mode again. When I put the M mode over there, I will see this movement. You see this movement? This is the movement that I am seeing. This is the movement of the diaphragm. This movement that you are seeing here is the movement of the diaphragm. Clear? And when I see this movement of the diaphragm, then I take the highest point over here and the lowest point over here, and I join these 2 points. That distance is called as diaphragmatic exertion. That distance in centimeters is a diaphragmatic exertion. Are you understanding? So what you can do is go to a normal patient, put the probe there, put the M mode, look at the diaphragmatic excursion, monitor this and see how much it comes. When he's normally breathing, so 2.5, 3, 4, itna sab aayega. 2.5 वगैरह आएगा. But when you see a person who is not breathing well, diaphragm is not moving well, it will be less than 1. This diaphragmatic exercise, that means the length from here to here. We can just put a caliper here and a caliper here and join that line. Are you understanding? That will tell you that this patient is not having satisfactory diaphragmatic excursion. Clear?
Okay, 1.8 minus.
क्या?
1.8 plus minus.
Oh, that's normal. That's normal. So this is normal. It can be 3, it can be 2, it can be 2.5, it can be anything. But if it's less than 1, you can clearly understand that the diaphragmatic movements are very poor. The chances of this patient having venous failure are high. The chances of having venous failure are high. You are understanding? So when the patient on GPS comes to you, it makes a lot of sense to the diaphragmatic movement because patient is not yet intubated. You understand? You can actually look at the diaphragm and understand whether this patient's diaphragmatic expression is happening or not. The second thing that you look at is diaphragmatic thickness. Diaphragmatic thickness. So what they have done, they have used the normal view that we just now talked about. They have put the mode over there and then they have seen this changes. You can see this now? Upper and lower leaflet, you can see the leaflet, this one. Okay, from the diaphragm, which when we go down, we'll show you how to do it. Okay, so when you this is done again from the mid axillary line. You put it. This is done from here. You turn it around, and then you will find the diaphragm. You will find the liver. Put the M mode over there. Look at what is there and see the thickness. So diaphragmatic thickness at inspiration minus diaphragmatic thickness at expiration divided by the diaphragmatic thickness at expiration is the DTP. It's called diaphragmatic thickness percentage. Something is called. Okay, diaphragmatic thickness percentage. Clear on this? So diaphragmatic thickness at inspiration minus diaphragmatic thickness at expiration divided by diaphragmatic thickness at expiration. If it is less than 30%, if this value is less than 30%, it basically indicates that the thickening of the diaphragm is not taking place. That means contraction is not good. You are understanding? So it has to thicken, no? Then it is going to work. The muscle is not thickening. If the muscle is not thickening, means the contraction of the muscles are not very okay. Okay, these patients have got a high chance of venous failure. So you can do both these tests in that patient down there. You can do both these tests in that patient down there to understand whether there is diaphragmatic weakness or not. Are you understanding? You're understanding what I'm telling you? Clear? Any doubts? So diaphragmatic ultrasound should be done very carefully. And you have now a patient in which you can do it. Otherwise you can do it other patients also. There are normal patients you can actually look at it. Are you understanding? So tomorrow if I want to figure out whether there is hemidiaphragmatic paralysis, that means patient has undergone cervical surgery and they have cut off from the 3-4 C3 C4 C5 or something, or kind of gastric surgery, and the vagus is or something is cut off from the C3 C4 C5 is kind of cut off. Then I will have hemidiaphragmatic paralysis. What I will notice? Curtain sign, no curtain sign. Simple. Paralysis agar ho gaya, then there will be no curtain sign only. That which I told in the start, there will be no curtain sign. So curtain sign, no curtain sign. Now this patient has been intubated, ventilated, and now having venous failure. What do? I keep the patient in the supine position, propped up, keep everything ready, keep my probes ready. Okay, keep my probes ready. Disconnect the patient, put him on he should be not on sedation, not be on paralytic agents, he should not be in anything. He should be on a pressure support mode of ventilation. You take off the pressure support, put him on a TPs, keep the probe. Immediately as he is breathing, put the M mode, freeze your image, put him back on the ventilator and check this. Look at diaphragmatic excursion and look at diaphragmatic thickening, DTP or E, what was called as. Diaphragmatic thickness. Okay. If it is less than 30%, in fact less than 25 or 20%, it clearly indicates that venous failure is imminent here. It's not ready for weaning. Whereas if that also is less than 1, so here is 1, right? 1.8, if less than 1, it indicates actually this patient will have difficulty in weaning. Not extubation, weaning. Extubation is different. We are talking of weaning. We are talking of patient, it's together only, but mostly we are talking about weaning here, weaning failure. Weaning from ventilator, weaning into our TPs. So this is that patient in which you cannot put on TPs only. Forget about extubation. You're understanding? Because you're trying weaning here. Other way around, you may want to try for GBS patients to see how much the diaphragm is working. Okay, these are the ways you can actually figure out whether the diaphragm is working or not. So if the patient of GBS is coming to you and you want to figure out whether this patient is getting weaker and weaker, you can do this. And you'll have a clear estimate as to what's happening.
After putting patient on TP.
A GBS patient, when comes from home to your ICU, he has been shifted from the ward. Now you want to figure out whether the diaphragm is working well or not. Simple thing, go and ultrasound.
Put on 20.
indicator for intubation?
It's not really indicated for intubation, but you have an idea, no? Ki the diaphragm is not okay. It's not been proven this way that you use a diaphragmatic exertion to figure out intubation. It's not been proven. But what we'll do is we will see, we'll at least come to know ki kya ho raha hai. Because GBS has not many diagnostic features that will make you for intubation. It's difficult. So it's a clinical call. So this will add to your clinical knowledge, no? Okay, this is what is happening. As the diaphragmatic thickness is not okay, diaphragmatic expression is not okay, this patient has got a high chance of getting intubated. You understand? That will come to your mind already. Like we don't have forced vital capacity, we don't have NIF, we don't have anything, right? So this will probably help you to understand whether this patient will require intubation or not. You understand? So see, all these things now looks very good when you read. You have to practice it out. Then you'll notice you'll start getting interested. Arey, wow, I saw this. You have to get to understand to use it in practice. You have to be interested to do it. If you are interested to do it, you will never forget it in your life. You understand? You will never forget it. I am telling you. एक बार तुमने किया ना, फिर तुम हर टाइम तुम अगर किया ही नहीं तुम सोचोगे नहीं आगे. You will not even think ahead. If you have never done it, you will never think only कि मेरे को next patient में करना है. How will you know when next patient करना है अगर तुमने इस पे किया है? I am surprised you are not using lung ultrasound the way it should be used. I'm surprised. Lung ultrasound. You should be using these lung ultrasounds. You will understand all these things much better. You have to use it. नहीं तो it's impossible. कल exam के लिए मत पढ़ो. वो life बाकी पूरा. हाँ? ठीक है?